It is indeed an absolute pleasure on behalf of a big group of authors to share with you our latest finding from this new publication on the cost of health system strengthening for small and sick newborn care in 4 African countries. This work can now be accessed in the Lancet Global Health by scanning the QR code. Why is this incremental costing analysis paper needed? Number one, to see impact in neonatal mortality. Our babies are still dying. In Africa alone, 1.1 neonatal deaths occur every year, and this hasn't changed much over the last 20 years. Number two, the implementation and investment gaps. Newborn survival is possible with a clinical package of small and sick newborn care interventions and health system change. But to do that, we need resources, which we still see gaps in both domestic and external financing. Number three, we need data. We see data gaps based on real-world implementation, which is needed to inform budgets. So, drawing on the largest published real-world neonatal implementation dataset in Africa, this paper will tell you the cost per hospital and per baby to implement small and sick newborn care and what the cost drivers are. This work is based on Nest 360, an alliance of 23 organizations working with 4 African governments and across 130 hospitals. They've been doing this since 2019 to drive change, including providing a bundle of devices, supporting clinical and biomedical teams with education, standardizing individual datasets, and enabling their use across various levels to drive change. The implementation and the recent analyses show a significant reduction in the in-hospital neonatal mortality. What was the package costed and which payer? We costed the hospital intervention package for level 2 newborn care and the system change based on the 10 core components. And this included infrastructure, HR, among others, from a health system perspective and has paid by the government and the Nest 360. The cost were across 65 neonatal units in these 4 African countries at scale in Malawi, both at the district and the referral hospital, subnationally in Kenya, Nigeria, and Tanzania, all in referral hospital, and we utilize various data sets for quantities that included the facility assessments, the patient level data, and the costing data. We use the Nest 360 programmatic financial records and government sources and other procurement records to source the unit cost. How did we add up the cost? So we estimated incremental change between pre-implementation and 1 year of steady state period, that is mid-2022 to mid-2023, and added cost across 3 levels: hospital level, national level, and the multi-country program support. At the hospital level, we were linking the incremental change for each input to price. At the national and multi-country level, we costed for activities linked to impact over time and personnel cost for the steady state period. All this we analyze by the cost type, whether it's capital or running costs, health system building block, and whether it was paid by the government or Nest 360. To derive the cost per hospital, we added hospital-specific change to the proportion of the national programmatic change and the proportion of the multi-country programmatic cost. And per baby cost was derived from per hospital cost by dividing that by the total admission in each hospital during the steady state period. In terms of the results, at the hospital level, the costs were fairly consistent across hospitals, lower in the district at 68,000 USD. Also, running costs were higher than capital, mostly much higher in bigger referral hospitals. In terms of the cost drivers, human resource was the top driver, contributing 40% of the cost. Infrastructure costs were minimal, in most hospitals, contributing at least 2% of the total annual cost, except in Tanzania, where the cost was slightly higher because of the government investment, which is standardizing, which they're currently working to standardize neonatal philosophies. At the baby level, the costs were influenced by the hospital admission. The cost ranged between 69 USD in Kenya and 150 USD in Tanzania, and higher in Nigeria, 265, due to low admissions and more intensive newborn care. So how do this measured cost compare to the national standard-based estimates for Tanzania? Tanzania is among the countries that have national standards for newborn health and have national investment case to inform scale-up based on two scenarios, best case scenario and halfway scenario. We compared similar level of care, that is a regional referral hospital, having similar admission numbers of around 3,000 per year. And what we saw from the cost, the measured cost was roughly close to the halfway scenario. And when compared to the best case scenario, 3 times more resources were needed, and specifically on the infrastructure and the HR. For this analysis, the measured costs have been catalytic and have had impact on neonatal mortality reduction, but it is evident that we still need more money for newborn care, at least 3 times more, mainly for infrastructure and HR to meet the government recommended staffing ratios, especially for nurses. Also, need to start budgeting for some of the crucial drivers of change, such as the data system and QI, that is very newborn specific, and also just budgeting for consumables and spare parts for devices for higher quality care. In addition to these findings, we continue to use this largest published comparable data to inform neonatal budgets and conduct more analysis, especially linking with neonatal mortality impact to estimate cost effectiveness and efficiency, and to be able to provide more evidence for quality care. We would like to acknowledge newborns and their families whose data made this study possible, the hospital teams for their dedication to improving newborn care, the Nurse 360 teams at country and multi-country level, and also the administrative teams for their commitment to collecting the data. Last but not least, we are deeply grateful to our funders, without whom this work would not have been possible. Thank you, and let us continue advocating for vulnerable babies who arrive early and deserve the chance to survive.